This talk is about clinical applications of somatosensory evoked potentials. It is intended for the Nicklaus Children's Hospital Clinical Neurophysiology Fellows. It will be conducted in a question and answer format. First question. Somatosensory evoked potential has A. General applications. B. Intensive unit care applications. C. Intraoperative applications. D. All of the above. Somatosensory evoked potentials can be used for confirmation of clinically detected neurological deficit involving the peripheral nervous system, the posterior columns, and the spinocerebellar tracts in the spine, the lemniscal system in the brainstem, and the lemniscal thalamic system in the brain. Somatosensory evoked potentials can also be used for assessment of subcortical and cortical integrity with aim of prognosticating outcome in patients with encephalopathy. And it also has intraoperative applications such as prevention of neurological damage by testing the neurological structures at risk for mechanical and ischemic damage, for monitoring of induced physiological changes such as hypothermia, and for localization of the central sulcus. So the answer to this question is D. Next question. Which of the following somatosensory evoked potentials would you use to study a patient with a suspected L4 root lesion? A. Superficial radial nerve. B. saphenous nerve. C. Superficial peroneal nerve. D. sural nerve. Patients with suspected root lesions can be studied by somatosensory evoked potentials. Those suspected of an L4 root lesion are studied using the saphenous nerve territory. So the answer to this question is B. Next question. Which of the following statements is true regarding somatosensory evoked potential and multiple sclerosis? A. Somatosensory evoked potential is recommended for the detection of subclinical issues. B. Somatosensory evoked potential is recommended to follow up the course of patients with multiple sclerosis. C. Somatosensory evoked potential can be used to test the integrity of the posterior column lemniscal pathway if vague symptoms of its involvement are present. D. Symmetrical delay interpeak latencies are typical of multiple sclerosis. MRI took away the prominent role of somatosensory evoked potentials used to have in the management of patients with multiple sclerosis. In the past, the usefulness of somatosensory evoked potential studies was that it would detect or confirm the presence of asymmetrical lesions in patients with MS. That is, lesions separated by time and space, but in the case of the somatosensory evoked potentials, separated by space. Symmetrical somatosensory evoked potential abnormalities occurred in patients with inherited ataxia, including Friedreich's ataxia. So the answer to this question is C. Next question. N20 remains present even at sedation levels sufficient to induce isoelectric EEG. A true, B false. Heavy sedated patients with flat EEG tend to have preserved N20. So the answer to this question is A. Next question. The Glasgow Outcome Scale score of dash indicates a high likelihood of impending death. A, 1, B, 2, C, 3, D, 5. The Glasgow Coma Scale measures the status of the comatose patient. 3 in this scale is the lowest score. The Glasgow Outcome Scale scoring system uses numbers from 1 to 5 to indicate outcome. 1 being dead, 5 being good recovery, able to return to work or to school. 2, 3, and 4 are different degree of badness. 2 worse than 4. So the answer to this question is A. Next question. Median nerve somatosensory evoked potential can be used to predict poor outcome after dash. A. Cardiac arrest. B. Friedreich ataxia. C. Multiple sclerosis. D. All of the above. This figure is from an article published in 2009 in the New England Journal of Medicine. It depicts a median nerve somatosensory evoked potential recorded at the brachial plexus, where it generates a potential, here labeled N9-10, but to which we usually refer to as the air point potential. A second potential recorded at the cervical spinal cord. This potential here is labeled N13. It is also called cervical N13. And a third potential recorded from the opposite cerebral hemispheres to the site of stimulation. This potential is called N20. In this paper, an algorithm was presented for the purpose of prognosticating outcome in patients following a cardiac arrest. It is applicable to patients in coma during the first 24 hours after arrest. The first step is to exclude major confounders such as renal failure and electrolyte imbalance. Once this is done, the next step is to check brainstem functions. If none is found, the prognosis is poor and we should proceed to do a brain death determination. Not being this the case, we must inquire regarding myoclonic status epilepticus. The presence of myoclonic status epilepticus indicates also poor outcome. Next come performing a median nerve somatosensory evoked potential. Absence of N20 between 1 to 3 days after a cardiac arrest indicates very poor prognosis. The algorithm goes on to evaluate the presence of serum neuron-specific anolase, and if elevated more than 33 micrograms per liter indicates poor prognosis. And on day 3, if the patient has absence of pupillary or corneal reflexes and no motor activity other than extension, it is considered to have also very poor prognosis. Otherwise, if none of these things are present, the outcome cannot be predicted. So, for our purpose, the important thing is that patient with absence of N20 1 to 3 days after a cardiac arrest have poor outcome. So the answer to this question is A. Next question. The absence of dash indicate worse prognosis after a median nerve somatosensory evoked potential. A. P24, B. N30, C. N20, D. P45. This abstract belonged to a frequently quoted paper. This paper is about clinical application of a standard somatosensory evoked potentials. It talks, among many things, about median nerve somatosensory evoked potential in relation to etiology and prognosis. To do so, it divides somatosensory evoked potential responses as cortical and subcortical. Cortical potentials are used to determine outcome. These potentials are N20, which result from the arrival upon area 3 of the cortex, that is area 3B of the cortex, thalamic input. N20 is maximal behind the central sulcus in the parietal region. P20, the positive pole of the same dipole producing N20, is maximal in the frontal regions. This figure shows the isopotential map of these potentials, where these potentials were more than 50% of their maximum amplitude. The crosses indicate the location at which the component, in this case the N20 and P20 components, were more than 90% of their maximal amplitude on the different subjects. So these crosses are, as expected, prominent in the area encircled, but they are also present in the areas outside the isopotential map. After N20, we have P24. I think that it is the same as the previously labeled P22. If so, it corresponds to the arrival of thalamic input to area 4, which occur in the frontal region. Next is P27. P27 results according to some from the activation of area 1 by fibers from area 3B. Next is N30. It is believed that this potential arises from the supplementary motor area, which, as you know, is in the frontal region, as you can see in this diagram. And finally, we have P45. P45, some believe, arise from the contralateral somatosensory area around the same area as N20 is generated, but it occurs long after N20 has already disappeared. I have added this somatosensory evoked potential to give you an idea of time and delayed potentials, since we have not ever mentioned P45 before in any of our talks. Now I have added the isopotential fields of some of the potentials that we are mentioning while answering this question. In this new frame, I have represented a timeline of the cerebral cortex potentials used for cortical assessment. After the sensory fibers cross to the other side in the internal arcuate fibers, the first scalp potential is N20. The absence of this potential may result from destruction of the cortex generating it or from failure of the thalamic activity to stimulate the cortex. The last potential in this line, as you can see, now pointed by the arrow, is P45, which, as we already mentioned, is generated also by the somatosensory area. These potentials have been used to design a system of prognostication based on level of severity, going from the best being 0 to the worst being 4. Level 0 is given when all potentials are present. Level 1 is given when P45 is absent and all other potentials are present. Level 2 is given when N20 and P24 are present and the rest are absent. Level 3 is given when N20 is present and all other potentials are absent. Level 4 is given when all the potentials are absent. As you can imagine, patients with level 0 have best prognosis. The patients in level 4 have the worst prognosis. So the higher the number, the worse the outcome. The answer to this question is C. Next question. Which of the following conditions would you be least likely to suspect if the sole abnormality present is a bilateral prolongation of the P14 to N20 interval? A. Drug intoxication. B. Metabolic disturbances. C. Hypothermia. D. Midbrain stroke. Whereas cortical potentials have only been used for prognostication, subcortical potentials can also be used to suggest localization, possible pathogenesis, which can lead to suspect a specific etiology, and prognosis. For these purposes, 3 parameters have been used to describe a level of involvement. The parameters used are P14 normalcy or absence. For recording P14, a cephalic electrode, usually in the centroparietal region ipsilateral to the stimulus, must be connected to an ear reference or another extracephalic reference, as is the contralateral ear point. The other parameter used is P14 to N20 interval. This interval is classified as normal, prolonged, or unobtainable because of the absence of either P14 or N20. And the third parameter is N20, described as normal, abnormal, distorted, or absent. This classification has 5 levels. Level 0 implies that all parameters are normal. Level 1A indicates that the only abnormality is prolongation of the P14N20 interpeak latency. Level 1A usually indicates brainstem or subcortical dysfunction, usually due to a reversible condition such as drug intoxication, metabolic issues, or hypothermia. Level 1B is characterized by the absence of P14 and an abnormal N20, thus making it impossible to determine the interpeak interval between P14 and N20. Level 1B is referred to as an uncertain pattern because it may occur with different pathologies and carries an uncertain prognosis. Level 2 consists of the presence of a normal P14 and a distorted N20. The distortion may be unilateral or bilateral. Level 3 is also characterized by a normal P14 and the disappearance or absence of N20. The word used in the classification is disappearance, which I assume, if the study has never been done before, that it implies absence. Level 2 and 3 indicate brainstem or subcortical lesion, as did level 1A. The difference is that those lesions are usually irreversible. So the answer to this question is D. Next question. Please take a look at this frame and try to determine the best answer. You can see 2 studies performed 3 days after a cardiac arrest in a 38-year-old patient that remains comatose and no sedation has been used. The question regards prognosis. A, good, which is consistent with a GOS of 5. B, bad, which is consistent with a GOS of 2 to 4. C, death, which is consistent with a GOS of 1. And D, uncertain. As we previously mentioned earlier in this talk, the Glasgow Outcome Scale scoring system uses numbers from 1 to 5 to indicate outcome. 1 is dead, 5 is good, and 2 to 4 are different degrees of badness. As we also previously mentioned, the absence of N20 indicates poor prognosis following cardiac arrest after 24 hours. Some say even before that. The article written by Kruku and associates goes deeper into the point of prognostication of patients with brain anoxia and brain trauma. In this case, we are referring to those with brain anoxia. So, patients with brain anoxia, by using the levels based on the previously described classification of cortical assessment and subcortical assessment, this author concluded that a prognosis of death or vegetative state can be given to patients with bilateral absence of N20 and preservation of P14 if these results were obtained more than 6 hours after an anoxic episode. This consists of a cortical assessment level of 4 with a subcortical assessment level of 3. This pattern is associated with no possibility of recovery, and according to the authors of these papers, justify waiving resuscitation. I find this last comment scary. 42 years of practice in medicine has wiped out any certainties regarding prognosis that I ever had. So, be it as it may, the use of the term ominous prognosis was reserved for those patients with level 3 cortical assessment. This implied those patients with only N20 potential being normal. The rest, from P24 to P45, being abnormal. And I assume that these patients will fall in level 2 in the subcortical assessment scale. The next prognostic category is denominated uncertain patterns, which include those with cortical assessment level 1 or 2 and subcortical assessment level 1A. Patients in this category have about 50-50 chance of recovery, that is, of good recovery. The last prognostic category indicated in this article is labeled good prognosis. Yet no description of it is given, and it is said that other tools for such prognostication should be used. The written text on the subject is far clearer. It reads, the bilateral absence of N20 with P14 preservation more than 12 hours and probably 6 hours after coma onset in anoxic coma has always been associated with death or permanent vegetative state. And there is no sufficient documented argument against this rule. This makes somatosensory evoked potential the most powerful tool for an unfavorable prognosis in anoxic coma. Conversely, mild altered somatosensory evoked potentials, which they describe as cortical assessment level 1, do not allow drawing any conclusions in terms of prognosis. So, going back to the study in question, not of any deciding influence, but interested to notice is that the stimulus given had long duration and high intensity, and therefore that high intensity was needed to provoke air point potentials, as you can see in this frame. Other potentials present are scalp P13 and N18. And in the relative closely placed scalp electrodes, we need to question whether N20 is present on the right. This constellation of findings, when matched with the level corresponding to the earlier discussion, reduces the usefulness of the study to supporting an uncertain prognosis, and to request a follow-up study. So the answer to this question is D. Next question. Please take a look at this frame and try to determine the correct answer. This frame has a somatosensory evoked potential performed on the right median nerve. The patient had a cardiac arrest. There was no hypothermia. It was still comatose on day 2. Glasgow Coma Scale was 3. CO2 testing revealed some gasping breath. The possible answers are regarding prognosis: A, good, GOS 5, B, bad, GOS 3 or 4, C, death or vegetative state, GOS 1 or 2, D, uncertain. The answering of this question requires 3 steps. The first step is interpretation of the study. The second step is knowledge of the Glasgow Outcome Scale system. And the third step is establishing a relation between somatosensory evoked potentials and outcome after brain anoxia. We will first consider interpretation of the study. As you can see, I have placed by the side of each derivation the expected potential. In this patient, the expected near and far field scalp potential, which I have placed by the side of each derivations, are not present. The missing potentials include the cortically generated and scalp recorded N20, the thalamic or tectal generated and scalp recorded N18, and the brainstem generated and scalp recorded P13-14, which are missing. The cervical generated and neck recorded N13 is present. The ipsilateral brachial plexus generated and trunk recorded air potential is also present. This table shows how median and ulnar potentials come to be. So, as you can see, this patient is not generating any potential above the cervical spine. It is important to stress that these findings must be bilateral. Only when these changes are bilateral, that is, the absence of cortical generated and scalp recorded potentials, that the interpretation of this test can be used for prognostication. In this case, especially to support the diagnosis of brain death. So, unilateral presence of scalp potential, regardless of degree of injury, they may reflect severe or mild as expressed in this frame. And certainly, if despite the absence of potential in one hemisphere, the other hemisphere is normal, the ability of using this scale for prognostication is very limited and likely to be wrong. Having taken care of the first issue in the answering of this question, we must address the second issue. This frame again shows the Glasgow Outcome Scale scoring system. And in this window, I have added the possible answers to this question. 5 in the Glasgow Outcome Scale scoring system corresponds to good. 4 and 3 to bad, 1 and 2 to death and vegetative state, as you can see. So after addressing the second issue, we must address the third and last issue, which is the relation between somatosensory evoked potential and outcome after brain anoxia. You have seen this frame before. I am presenting it to you again so we can recall that patients with brain anoxia with absence of N20 and preservation of P14 have a very poor prognosis, which is equivalent to death or permanent vegetative state. So it is reasonable to consider the same prognosis when only cervical N13 is present and neither P14 or N20 are present, as it is in this case. So the answer to this question is C. Next question. Please take a look at this frame and choose the correct answer. The frame consists of two somatosensory evoked potentials performed 9 days after cardiac arrest in a patient that is still comatose, of hypothermia, and no sedation. This study was presented to you in a prior question. As you can recall, it had been done, that is, the first study was done 3 days after cardiac arrest. And at that time, brainstem and thalamic scalp recorded potentials were present. And possibly the right hemisphere cortical generated scalp recorded potential was also present. This pattern at the time was considered to provide an uncertain prognosis, and it was requested for the study to be repeated at a later date. In this frame, I have added the study presented in this question. As you can see, this study required less stimulus duration and intensity than the first study that was done in the same patient. You can also see in this new study that the brainstem or thalamic generated scalp recorded potentials are clearly present and tagged by the machine, and you can also notice that the cortical generated scalp recorded potential is very clearly noticeable in both hemispheres. This certainly indicates an improvement. Yet, when it comes to prognostication, we must remember that when dealing with brain anoxia, even in the presence of preservation of cortical potentials, the prognosis is uncertain. So the answer to this question is D. Next question. Please take a look at this frame and choose among the possible answer the correct one. It is related to head trauma, coma, no sedation, with a Glasgow Coma Scale of 3, day 2 after head trauma. The possibilities are prognosis, A, good, B, bad, C, death or vegetative state, D, uncertain. The prognostication value of somatosensory evoked potentials in patients with head trauma has also been studied. A prognosis of death or vegetative state is linked to somatosensory evoked potential patterns of brain death, that is, absence of brainstem and brain generated potentials. Using the Cortical Assessment scale, this will consist of level 4 Cortical Assessment Deficit, but no level from the Subcortical Assessment scale can be applied to this finding. A point to consider is that the finding in this study can be used to support brain death. Brain death is diagnosed based on the absence of cerebral and brainstem clinical function supported by an isoelectric EEG and at times also supported by the absence of cerebral and brainstem potentials after somatosensory evoked potential of the median nerve. All this, that is the use of the somatosensory evoked potential as a confirmatory test of brain death, has to be done only in those cases that the study is technically sound. The soundness of a study is confirmed by the presence of peripheral nerve potential with or without spinal potentials. As you recall, the highest potential present in this patient was cervical N13. It is interesting that no statistical information or remark is made about this given situation in this paper. The prognosis after head trauma is ominous when N20 is bilaterally absent. This corresponds to cortical assessment level 4 and a subcortical assessment score of 3 or level 4. In these patients, in the article, it is presented that less than 50% have good recovery. In the text, it states more clearly that is up to 50% in this group have good recovery. I think that this means that even in the absence of bilateral N20 in patients with head trauma, the possibility of a good outcome is, although small, significant. Next, in the prognosis scale, in the article, we have a classification that uses the term of uncertain pattern. This classification is given to those with subcortical assessment level of 1A, yet it is stated that in order to do so, other studies such as visual evoked potentials and VERA are required. It is not clear in my mind what is the use of this test for prognostication, but they are included there, so therefore I am mentioning them. Finally, the last category is good prognosis. In somatosensory evoked potential pattern following head trauma is consistent with good prognosis when the subcortical assessment is 0, as been pointed out in this frame, and the cortical assessment is 1 or 2. And I assume also 0, although it's not mentioned in the chart. In these circumstances, the likelihood of a good recovery is more than 80%. In the same article, the written test section states that bilateral absence of N20 has been associated with recovery in about 15% of the cases, and that mildly altered somatosensory evoked potential in the absence of brainstem dysfunction has been associated with a good recovery in 80% of the cases, when the cortical level assessment is 2 and 90% when the cortical level assessment is 1. So the answer to this question is D. Next question. After head trauma, once cortical potentials are lost, they do not return. A true, B false. This frame follows the median nerve somatosensory evoked potential in a patient with head trauma. The first study was done 2 days after the head trauma. And as you can see, there is cervical potential with right median nerve stimulation and a cervical potential with left medial nerve stimulation. The cortical potential in the left hemisphere and in the right hemisphere are missing. Now comes 4 weeks after, and as you can see, the cortical potentials are present. So the answer to this question is B. Next question. Which of the following statements is not true? A. Any potential present in a scalp derivation precludes the diagnosis of brain death. B. When the only abnormality is a prolonged P14 to N20 interval, the pathology tends to be reversible. C. In the presence of cervical N13, the absence of P14 and N20 indicates significant pathology. B. Potentials P24 and P27 are used for routine median nerve somatosensory evoked potential assessment. The assessment of brainstem and cerebral structures based on the presence or absence of median nerve generated potential can start by analyzing P14. If P14 is absent, our attention should go to N20. If we find it present, further prognostication can be achieved by checking later cortical potentials, that is, by going to the cortical assessment scale. If, on the other hand, N20 is absent, the study can be classified as presenting an uncertain pattern, but to do so, the spinal and peripheral nerve potentials should be present. If not present, we must consider the possibility of technical issues or brain death. If, on the other hand, P14 is present, we should then analyze N20. If absent, then we should conclude that either brain or brainstem pathology is present. If, on the other hand, N20 is present, then the thing to do is to check the P14-N20 interval. If prolonged, the odds are that a reversible pathology is present. If the interval is normal, cortical assessment may be carried out. It is important to stress that cortical assessment is not routinely done. In most intensive care units. So the answer to this question is D. Next question. Longer than routine sweeps are needed for cortical assessment. A. True. B. False. The usual sweep used for median nerve somatosensory evoked potential is 40 milliseconds. For cortical assessment, the sweep should be increased to 80 milliseconds. This is so in order to make sure that we capture P45. So the answer to this question is true. Next question. In anoxic coma, median nerve somatosensory evoked potential can predict bad outcome but cannot predict good outcome. A. True. B. False. As you recall, in the New England Journal of Medicine, an article was written back in 2009 that stated that the absence of N20 1 or 3 days, that is 1 to 3 days after cardiac arrest, indicate poor outcome in a comatose patient. The prognostication based on cortical assessment put forward in Krukus' article is more cumbersome, but it also provides more precise information regarding outcome. And in addition to providing likelihood of outcome for patients with anoxic coma, also does the same for patients with head trauma. In this question, we are referring to anoxic coma, which occurs after cardiac arrest. In the case of anoxia, as the one that we have just mentioned, after 12 hours of the event, if no technical abnormalities or issues are present, we should assess the cortical assessment score. When there is bilateral absence of all cortical wave, the likely outcome is death or vegetative state. And it is stated in Krukus' article that resuscitation in this condition should be waived. If N20 is missing unilaterally, or if N20 is present but all subsequent waves are missing, the prognosis for good recovery is less than 10%. If all cortical potentials are present except for P45, or if the potentials not present are P27, N30, and P45, the prognosis for good recovery is only a 50-50. So the answer to this question is true. Next question. In head trauma coma, extended median nerve somatosensory evoked potential can predict good outcome, but not bad outcome. A. True. B. False. The story with head trauma is different. In the case of head trauma, even those with bilateral absence of N20 and all other wave bilaterally have a 10 to 15% chance of good recovery, while those falling in level 1 and 2 of cortical assessment have an 80% chance of good recovery. I assume those falling at level 0 also fall in the same category. So the answer to this question is true. Next question. Please take a few seconds to look at this frame and determine the correct answer. In this patient, there was no mention of trauma, and the somatosensory evoked potential was done 2 days after rewarming. The patient was still comatose and no sedation was used at the time of the somatosensory evoked potential. The prognosis was considered as A, good, B, bad, 3, uncertain, D, very bad, or death. As you can see in this study, N20 is missing bilaterally, and brainstem and thalamic potentials are present bilaterally. These findings must be correlated with the Glasgow Outcome Scale scoring in order to answer this question. As you can see in this figure, with the added text, the following comments can be asserted. When bilateral absence of N20 with P14 preservation more than 12 hours and probably even 6 hours after coma onset, in anoxic coma, the outcome is always poor. The outcome is either death or permanent vegetative state. So the answer to this question is D. Next question. Please take a look at this frame, check the studies and the history, and try to determine the correct answer. A, good, B, bad, C, uncertain, D, very bad, or death. This is a normal study, but such findings in the case of an anoxic coma does not allow us to draw any conclusion regarding prognosis. So the answer to this question is C. Next question. Giant somatosensory evoked potentials are found in patients with cortical myoclonus. A, true, B, false. This article was written many years ago. It describes the association of grossly enlarged somatosensory evoked potential in a patient with right hand cortical myoclonus. In this frame, as you can see, there is a representation of a left-sided stimulus provoking a right cortical potential and also a cervical potential. And as you can see, these potentials are normal. Now, with right-handed stimulation, you can see that the left cortical potential labeled P1 and N2 are extremely high. Please compare them to the ones on the other side. I think the reason the cervical potentials are also large is because the cervical potential were referred to FC, and therefore the potentials reflect the scalp status and not the cervical spine status. So the answer to this question is true. Next question. Brain death can be diagnosed in the presence of A, N18, B, P14, C, N20, D, N13. The cervical potential is called N13 and P13. As you know, the diagnosis of brain death can only be established in the absence of brainstem and cerebral function, and therefore any potential occurring in the brainstem or in the brain exclude the possibility of brain death. So the answer to this question is D. Next question. Take a few seconds to look at this frame and choose the correct answer. And the question is if whether you feel after looking at this frame that there are no chance for full recovery. A true, B false. This recording was obtained on a comatose patient with carbamazepine levels of 81 microgram per ml, normal being 2 to 8 microgram per ml. As you can see, the scalp potential show no activity, whereas those obtained from the air point show good activity. Now, 7 days later, this study is repeated, and here, as you can see, the scalp potentials have returned. Notice that the Glasgow outcome score is 5, indicating a very good prognosis. So the answer to this question is B. Thank you very much for your attention.